It's normal, it can happen. Okay, so it's not cancerous, and dysplasia is cancerous. So for example, if a person is having, let's suppose this is his cancer and this is his normal cell, right? So in between this phase you are going to see a process that is dysplasia, right? So dysplasia is a precursor or pre-malignant condition. It can like the normal cell, if it's converting into a carcinoma, so first it have to undergo dysplasia, which is like pre-cancerous condition, right? So this dysplastic, like before development of squamous cell carcinoma, it means before development of squamous cell carcinoma, we would be seeing some dysplastic intermediate phase as well, right? Is that right?
Mhm.
Okay. So
Yes.
what's that dysplastic phase, like the pre-malignant or dysplastic phase? That is basically known as your leukoplakia, right? Or erythroplakia. Okay. So as the name suggests, leuco mean white, right? Leukocytes for your white blood cells. So white, and plakia mean plaques, right?
Mm.
So on gross examination, the dysplastic condition is going to appear as white plaques, as the name suggests, right?
Mhm.
Hello? Okay. Here you guys can see that erythroplakia, erythrocytes for red blood cells, right? So can I say red plaques, right?
Yeah.
So as the name suggests, okay, we were discussing about squamous cell carcinoma. We already discussed that before developing into squamous cell carcinoma, you should have a dysplastic intermediate step. Okay, like you have two steps, let's suppose, for the formation of carcinoma. So you are going to see dysplasia. So these dysplastic condition, like the or the pre-malignant condition before development of squamous cell carcinoma is like leukoplakia or erythroplakia. As the name suggests, leuko for white, plakia for plaques, erythro for red, plakia for plaques. So you are going to see white plaques or red plaques. But what's the problem? White plaques can be seen in many other conditions as well. So now you have to rule out those conditions. For example, if a person is having oral candidiasis, like we already discussed in patients with asthma, we basically give them glucocorticoids, right?
Mhm.
Glucocorticoids are immunosuppressant. So we just advise these patients to wash their mouth right after using that inhalator, so that the glucocorticoids cannot remain inside your oral cavity. Why? If the glucocorticoids remain inside the oral cavity, it would decrease the immunity there, and you can have opportunistic infection. For example, candidiasis, right? So it
Yes.
would grossly, the candidiasis is also going to appear as white plaques, right? Is that right?
Mhm.
Yes.
Okay. So, for example, if I am on gross examination, I am seeing white plaques. So, we can have two things. Either it can be leukoplakia or either it can be oral candidiasis as well. So, how to differentiate both of them? It's very simple. Take the tongue depressor and scrape off the white plaque. If you can easily scrape off the white plaques, it would suggest that it's not leukoplakia, it's oral candidiasis, right?
Mhm.
You have candida, and if you cannot scrape off those white plaques, it would suggest you have leukoplakia, right?
Mhm.
Okay. So you also have another differential on this chart as well. That is basically known as hairy leukoplakia. So hairy leukoplakia also isn't a dysplastic condition. Like in this hairy leukoplakia, it can be like in those patients who are immunocompromised. For example, those who have AIDS or those who have EBV induced squamous cell hyperplasia. It's hyperplasia, right? They can have hairy leukoplakia as well. Like it isn't dysplastic condition, not pre-malignant condition. Okay, so how to differentiate this? Because it would also appear as white plaques, but this time very high yield. It's going to be present on the lateral side of your tongue. So whenever you have white plaques on the lateral side of your tongue, okay, it's called hairy leukoplakia because you're going to see rough kind of these plaques, right? Okay, so we were discussing about the dysplastic condition, leukoplakia. So once we are looking for leukoplakia, so we have three differentials for leukoplakia. We can have the dysplastic leukoplakia, the true leukoplakia. Secondly, oral candidiasis can also give us white plaques on tongue. Thirdly, leukoplakia, which is due to immunocompromised state, AIDS, or EBV induced squamous cell hyperplasia. It can also give us white plaque. How to differentiate all of them? First of all, take the tongue depressor, scrape it off. If it can be scraped off, yes, it's oral thrush or it's oral candidiasis. Secondly, look whether it's only present on the lateral aspect of your tongue, it's hairy leukoplakia. And if it's present all over the tongue and you cannot scrape it off, now it's your true leukoplakia, right? Okay. Now let's discuss erythroplakia as well. Okay. It's leukoplakia. You know the cancerous cells, why are they called cancerous cell? Because they love to proliferate more, right? Right? They like proliferate. They grow in their size. And for the growth, they need blood as well, right? Hello. They need blood vessels for growth. They need energy for growth, right? Nutrients for growth. Hello.
Yes.
Okay. It means that if I am seeing some red plaques, which are suggesting red blood vessels within the plaques, it would suggest that they are more close to your carcinoma, right? Squamous cell carcinoma, because these like this increased amount of blood vessels in these plaques are going to suggest that these are like actively dividing cells. They have more blood supply here, so they are close to your squamous cell carcinoma, right? These are basically the intermediate. So if you are seeing red plaques, so it would more likely suggest that this person is going to develop squamous cell carcinoma, right? So this was all about squamous cell carcinoma, and you know it's carcinoma. It's a malignant neoplasia of your squamous cell, right? And what are the risk factors? Yes, tobacco and alcohol. Why? We discuss a general term. Whenever you have irritation for chronic period of time to certain epithelial structures, it's going to lead to carcinoma. So tobacco, those who are using tobacco, they just like smoke for 20 years, right? Alcohol, like these are some chronic irritants which can chronically irritate your mucosa, and chronic irritation can lead to carcinoma, right? Hello.
Yes.
Okay. So now you guys are going to tell me, okay, Dr. Renu is going to give us an overview about squamous cell carcinoma. We had a long conversation on this topic. Yes.
Yeah, so squamous cell carcinoma is like okay, so first is like dysplasia and metaplasia, which metaplasia is like the normal thing, normal physiology. So like one cell type is getting converted into the other cell type, which is normal. But dysplasia is like precancerous.
Okay.
In dysplastic phase, we will see leukoplakia and erythroplakia.
Yes.
Leukoplakia, as the name suggests, leuko means white, so they are like white plaques, and erythroplakia means like red plaques.
Yes.
Okay, now coming to the white plaques. So, white plaques can be seen in other conditions as well, apart from squamous cell carcinoma. It can be seen in like asthmatic people who are using oral glucocorticoids, so that can present as oral candidiasis.
Yes.
And it can also be seen in hairy leukoplakia, which is seen in immunocompromised people like AIDS or in EBV. In EBV, we have
Induced hyperplasia of
yeah
your squamous
squamous
cells.
cell.
It's hyperplasia. It isn't any
Uh,
cancerous form, right?
okay, it is hyperplasia of the squamous cell. In
Yes.
that condition also we can see white plaques. So how to differentiate these three is we'll take a tongue depressor, and if the plaques are getting scraped off easily, that means it's oral candidiasis.
Yes.
And if it is not getting scraped off, then that means it is a squamous cell carcinoma. And if
Yes.
the white plaque is present on the lateral side of the tongue, that means it's hairy leukoplakia.
Yes.
And erythroplakia is like red plaques. We know like the cancer cells are the rapidly dividing cells and they need blood to grow rapidly. So whenever we see red plaques, it is highly suggestive of some carcinoma.
Yes. Okay.
And the
So
risk factors include tobacco and alcohol.
yes. So we discussed like in the last one, once we were discussing our lungs, right? So lungs can also have squamous cell carcinoma. If you guys remembered, squamous cell carcinoma is going to release PTH, right? This was one of your NBME MCQ as well. Okay. You are going to see hypercalcemia and everything. So what happened in squamous cell carcinoma? We discussed we are going to see keratin pulse, right?
Yeah.
Keratin pulse with desmosomes. Remembered?
Yeah.
Okay, so in this section, for example, on the immunohisto graph, if you see these pearl-like structures, so you're going to see MCQs on that, right? So these are a spiraling kind of pearls, which suggests that you have keratin pulse, and keratin pulse are highly suggestive of squamous cell carcinoma, right?
Yes.
Yes. Okay, so this was all about oral cavity and the pathologies. Now let's move towards salivary glands, right? Okay, so salivary glands. So you guys know that we have like three major salivary glands. That is your parotid gland, yes, submandibular and sublingual, right? Okay. So these are exocrine glands, right? What do we mean by exocrine glands? Hello, hello.
Their action is near the secretion.
Okay, exocrine means that for their secretion they use ducts, right? Like they are directly using ducts in order to dump their secretions simply. Okay, so the first condition which we'll be discussing is mumps. Do you guys know what is mumps? Hello, mumps virus. Hello, hello.
Yes,
No
doc.
responses today. Mumps virus. What's mumps virus? What's it going to do?
It causes bilateral parotitis.
Okay, so in Picturize you have like very interesting picture of mumps, right? So there was a person who was just like an archaeologist, right? So he just entered like a spot where he just found a mummy, right? Okay, so once he found the mummy, so the mummy raised. So what did he do? Okay, let me just show you a picture. Give me a second, right? Hello, can you guys hear me?
Yes, doc.
Yes.
Just a second. Okay, so here you can see that you have an archaeologist here. He just found a mummy, right? So okay. So what did he do once he found a mummy? He just hit the mummy with a pen. Here you can see, right? And on the head, the mummy got a bump, right? And with that, he just kicked the mummy in between his legs, right? You can see there. And with that, the what did the mummy do? He just was blowing out air from his mouth. So you can just remember this picture, right? So the hitting with pan suggests that you are going to see pancreatitis in, okay, mummy for your mumps, right? Or in the memory of mummy. So mummy for mumps virus, it's going to cause pancreatitis. The like this guy is hitting the mummy with pen, right? So pancreatitis. Okay, with that hit, the mummy develop a bump on his head. So the bump on his head is going to suggest you aseptic meningitis, right? It's going to give you aseptic meningitis. And as the guy just kicked the mummy between his legs, so it's going to give you orchitis. You guys know what is orchitis? It's like inflammation of your testicles, simply, right? And it can lead to infertility, right? Okay, and another thing, the mummy is just like blowing off air from his mouth. So parotid glands, parotid glands are like close to your cheeks, right? Here, like in the cheek area, mainly the parotid gland is present, and you have facial nerve which is passing through the parotid gland, if you guys remember the anatomy, right? So it's also going to cause parotitis, right?
Mhm.
Okay. So anyone who can just give us an overview of mumps? Okay, let me just give you a quick overview. Mumps is like a virus. It's going to give you inflammation of parotid gland. It's going to give you pancreatitis, orchitis, aseptic meningitis, and parotitis, right?
Mhm.
Okay. So can you just can anyone just give me a quick overview so that we can just move forward then? Hello.
Okay, so mumps virus is like the mummy is the mumps virus. Hitting with the pan is pancreatitis. The bump in the head getting aseptic meningitis. And then the guy kicking in between the legs, that means like orchitis, inflammation of the testicles, which can further
Okay.
lead to infertility. And
Yes.
then the swollen cheeks tells us that it's like parotitis.
Okay. So basically the mumps virus. Okay, we are done with the mumps. Now let's move salidinitis. So what is salidinitis? As the name suggests, itis is inflammation, right? So salidinitis basically suggests that those who have inflammation of their salivary glands is salidinitis, right? So we just discussed a single rule. If you guys remember that, for example, these are our salivary glands and you have ducts, right? So we already discussed that, for example, if you have blockage of the duct system in the salivary gland, so you're going to see stasis, right? And like stasis of secretions. So you have your acinus. Acinus is going to drain all of its secretion into your duct. So for example, if let's suppose if in the salivary gland a person develops, let's suppose, stones, right? Salolithiasis. Okay, and these stones are obstructing the duct. So it means you're going to see stresses of secretions in the back in the gland, right? So whenever there is stasis, stasis leads to infection, right? Okay. So
Mhm.
stasis leads to infection. And what's a common bug which causes this inflammation or infection of your salivary glands? That is your Staph aureus. Okay, so Staph aureus is going to lead to this inflammation. Okay, and what's the reason? Obstruction. It can be due to stone and Staph aureus. Okay, another pathology which we are going to discuss that is related to your salivary gland is an adenoma. That is your pleomorphic adenoma. Okay, so the first thing which you guys must remember is that a pleomorphic adenoma is benign tumor of your salivary glands. The most common site where the pleomorphic adenoma arises is your parotid gland, right? Okay. So remember, guys, if we have benign, what does benign mean? That it won't spread, it won't invade, right?
Mhm.
Hello. So we discussed that in between your parotid gland, the facial nerves also passes, right? This is your facial nerve, which is passing through your parotid gland, right? So, for example, if someone is having a benign mass here, so benign do okay, what's the features of benign mass? It won't invade, it won't invade your local structures. That's why it's benign. So it means that in case of any benign tumor, like in this case, pleomorphic adenoma, you won't seeing invasion of the tumor into the facial nerve. If I'm not seeing invasion of the tumor into facial nerve, it means it would be a painless tumor, right? If the nerve isn't involved, so it would be painless.
Yeah.
Okay, so it would be well circumscribed and it would be mobile. What does the mobile suggest? Mobile mass that it haven't invaded the structure. That's why you can easily move it with your hand simply, right? So you're going to see a mobile structure without any pain. Why? Because it's a benign tumor. Okay, and the most common area inside the parotid gland, which it's like commonly occurs, is your angle of jaw, and it's the most common tumor of your salivary gland, by the way. Okay, so another point which you guys must remember that this tumor normally have like rough edges, like irregular or rough edges. So it's very hard for the surgeon to resect each and every like component. Like even like a trained surgeon can also have like some remnant of the of this tumor. Why? Because of its irregular structures. So that's why this tumor have high rate of recurrence, right? So it can recur if you if some of the tissue is left behind, so it can recur, right? Okay, so well
Mm.
circumscribed mass of at the angle of jaw, it's most common tumor in the parotid. Okay, pleomorphic. Pleomorphic means that you are going to see some different kinds of things. Pleomorphic, different like structures within this tumor. And what are those different things? Yes, it's basically you're going to see stroma, that is cartilage within this tumor mass and epithelial tissues. So this benign tumor basically consists of stroma or cartilage with epithelial tissues, right? Okay. So anyone who can just give me a quick overview of this tumor so then we can move forward.
Dr. Ahmed,
Yes.
um, you said it is benign, so it is like well circumscribed, and then
Yes.
you said it has like irregular edges.
Yes.
Can you please explain? I
Okay.
mean, like well circumscribed means it has clean edges.
Okay, so it's like a well circumscribed in a sense that, okay, if you just see the tumor like grossly, so these
Mm-hmm.
edges are not like as I have drawn it like a big edges. So you have a like even if you left a little amount of cells behind, so its edges are irregular basically, right? Like you cannot like it do not invade if it was malignant, like you are thinking of that if
Uh-huh.
like for the malignant you know that the invasion is extensive. It can just spread like throughout your like as here I have discussed, if it was malignant, so it's going to like give you facial pain. Why? Because it have to invade the nearby structure, that is your facial nerve. But if you are grossly looking like with microscope, you are looking to this tumor, so the edges are quite irregular.
Irregular.
Like so these are some broad views which you are looking like broadly. If speaking, it won't invade structure, right?
Mm-hmm.
Why? Because you won't see any facial you won't see any pain, so it means it haven't invaded your facial nerve. Secondly, it's mobile, you can move it. But if you just like zoom in the picture and
Mm-hmm.
see, so it have irregular borders. Like we are only zooming in the picture, right?
Right, right.
Because for the resection you won't leave any like even a single or like a little bit cells,
Mm.
because it can reoccur. So if I'm just zooming in the picture and I'm looking, so it have regular irregular borders, so that's why it have increased chances of recurrence, right?
Yeah.
Okay, so this was okay. So now let's just discuss another tumor, which is Warthin tumor, right? Okay, so first of all, just give me an overview, then we are going to move forward.
Okay, so salidinitis is like inflammation of the salivary gland,
Okay.
and it can happen like when there is some obstruction in the duct, so the secretions are not flowing out, and it is getting built up, which can lead to infection. And the most common organism is the Staph aureus.
Okay.
Yeah. And then pleomorphic adenoma. Pleomorphic adenoma is the benign tumor of the salivary gland and most commonly the parotids.
Okay.
So,
Good.
yeah, since it's a benign tumor, so it will not invade the nearby structures like on the parotid gland. Over the parotid gland, the facial nerve is running. But since it's benign, it will not invade the facial nerve and therefore it will not cause any pain. So it will be a painless thing.
Yes.
And it is like well circumscribed and mobile.
Yes.
And but microscopically we see the irregular edges, so even if like we remove it but still bits and pieces are left, therefore it has like chances of recurrence. And the most common location is at the angle of the jaw.
Yes.
And along with it we can see like different structures as well, like the stroma, like the cartilage with epithelial mass.
Okay. So another mass which we'll be discussing is Warthin tumor, right? So what's Warthin tumor? In this, it's also a benign cystic tumor, and again, the common location which it arises is your parotid glands, right? So it arises in the parotid gland. So what happens in Warthin tumors? You are going to see lymphocytes. In this case, you are going to see lymphocytes plus germinal centers within the parotid gland. So, guys, if we are thinking of germinal centers and lymphocytes, so this characteristic is highly suggestive of lymph nodal tissue, right?
Yeah.
Because in lymph nodal tissue, we are saying that we are going to see lymphocytes and germinal centers. But here now in the salivary glands, we are seeing this. So what basically happens that the parotid gland is the last gland which is like, simply you can think of, it's the last structure which is separated from your remainder things, right, embryologically. So sometimes what happens, you can see some nodal tissues, lymph nodal tissue that are present inside your parotid gland, like they do not separate well from one another. Sometimes this happens, right? So if they do not separate from one another, and if you have overgrowth of that remnant of the lymph nodal tissues, so it can lead to a tumor, that is your Warthin tumor. Simple, right? So what's the basic idea? Parotid gland is the last gland which segregates or which separates from the other structure of your faces. But sometimes what happens, you can see some remnant of lymph nodal tissues within the parotid gland. And once these remnant of lymph nodal tissues are uh, like um, they divide or they just like proliferate, so it can lead to a tumor, and that would be your Warthin tumor. So if you see these tumors within the histopathological slide, so you're going to see a lot of lymphocytes, a lot of germinal centers. You guys know what is germinal centers? That's secondary follicles in which B cells are going to grow. So you're going to see B cells and T cells. So simply you can think of this is Warthin tumor, right? And it's the second most common tumor of your salivary gland. Is that clear? Okay. So now let's discuss some pathologies of esophagus. So the first pathology, yesterday we discussed the tracheoesophageal fistula. So the common type. So Dr. Rino is going to give us an overview of the common type of TE fistula and its presentations and everything.
Okay, so tracheoesophageal fistula, the most common type is like the distal type.
Okay, distal. So what happens in this?
So there will be like drooling, choking.
Okay, so first of all, the esophagus proximal part is going to end into a blind tube, and the distal is going to be attached with your like
Trachea.
that, right? Yes, drooling, choking. What about abdominal distension, aspiration, pneumonia, right?
Right.
Okay, so the second pathology which we'll be discussing is esophageal web. So anyone who can just tell us what is esophageal web? Hello, yes, Dr. Renu, do you know what is esophageal web?
No, dog.
Okay, so you know you have your mucosa, which is present inside your esophagus. Simple. So sometimes what happens, you can see an outgrowth of this mucosa like that, which is like constricting or which is restricting the lumen of your esophagus, right? So this outgrowth of mucosa, which is like thinning the lumen of your esophagus. Here you can see it is thinning the lumen of your esophagus, right? If it's outgrowing, and if just okay, so this is your esophageal web.
Mhm.
Your esophageal web. Simple. Okay. So what happens if I'm having this outgrowth? So what would be presentation? That's also simple. If I'm just ingesting some unchewed food, so we'll be seeing dysphagia, right? Dysphagia. Why? Because already this esophageal web have thinned the lumen of esophagus. Is that right? So this is your esophageal web. Okay. We already discussed if the food is just coming here when it's like building up here. It means it can, the food particles can irritate your mucosa, right?
Yeah.
Hello. So can I say that this irritation lead to carcinoma? Hello.
Mhm.
Okay. So the idea is simple. If we have thinning of this esophageal lumen with this esophageal web, what is web? It's simply an outgrowth of the mucosal layer. So we'll be seeing building of food above this web. So it would chronically irritate your mucosa, and chronic irritation is going to lead to
Carcinoma.
squamous cell carcinoma. Simple. And you're going to see dysphagia with poorly chewed food, right? So you have a syndrome which is known as Plummer-Wilson syndrome, which is associated with Plummer-Wilson syndrome. Okay, can anyone just tell me what is Plummer-Wilson syndrome?
There is iron deficiency anemia,
Okay, iron,
esophageal webs,
okay, deficiency anemia plus esophageal web. Yes, red beefy tongue.
spoon-shaped nails,
Koilonikia.
Okay,
koilonitis.
coilinity. Okay, so it's a syndrome.
Koilonikia.
Okay, what do we mean by syndrome? If you have a lot of pathologies all at once, it's a syndrome. So in Plummer-Wilson syndrome, you're going to see this esophageal web. Along with that, iron deficiency anemia and atrophy of your tongue, and as a result of that atrophy, your blood vessels are going to be exposed, giving you red beefy tongue. Right. So this was all about esophageal web. Anyone who can just give us a quick overview so that we can move forward then.
Okay, so esophageal web is like the mucosal outgrowth. When the mucosa is outgrowing, so the food, the unchewed food, it can present with dysphagia. And
Okay.
since above it the food is getting lodged, it can chronically irritate the walls of the esophagus, which can further lead to carcinomas.
Okay.
Yeah, and there is one syndrome associated with esophageal webs, which is the Plummer-Vinson syndrome. So, along with esophageal webs, we see iron deficiency anemia, red beefy tongue, and
Oil.
koilonitia.
Okay. So now let's discuss another pathology which is Zenker diverticulum. Zenker diverticulum. So before discussing Zenker diverticulum, can you guys tell me that what's the difference between false diverticulum and true diverticulum?
The true diverticulum has the muscularis layer.
Okay, it it have all those three layers, right?
Three layers, yeah.
Okay, and false diverticulum,
Only mucosa and submucosa, no
okay,
muscularis.
mucosa and submucosa, it's going to pierce your muscularis layer, and then it's going to give you a diverticulum, right?
Hmm.
Like you won't be having all these three layers. So Zenker diverticulum is an example of false
False.
diverticulum. Remember that, right? So here in the pharynx, just let me just give you, for example, in the pharynx you have like muscles, right? So what happens in between those muscles? You have a fibrous ring in between those muscles. Remember that, right? Your pharyngeal muscles. That is your stylopharyngeus, and I just remember forgot the other name. I'll be okay. So the main idea is that these two muscles, in between these two muscles, you have a fibrous ring. Okay, so this is normally like weak kind of ring. So if someone is eating food and this ring can just extend like that, and it can just give you a false diverticulum. So okay, it's like above your upper esophageal sphincter between these two muscles in that fibrous ring. Remember. So, for example, if you have this diverticulum, so with time, what happens? The food can just become trapped in with this diverticulum, which is going to rot. The food is going to rot, and it's going to give you bad breath or halitosis, right?
Mm-hmm.
So, and this patient would be complaining of dysphagia as well. Like he would be saying that I have something stuck in my neck, simply, right? Or some food stuck in my neck. It would just give that sense of fullness or sense of obstruction, right? So, for example, if this is full with a lot of food, it can also compress the esophagus, which is going to give you dysphagia, right? Is that right?
Mm-hmm.
Okay. So dysphagia, obstruction, and halitosis. As the food is accumulating here, it can just rot and it can give you bad breath or halitosis. Okay. So another syndrome which we will be discussing is Mallory-Weiss syndrome. Anyone who can just tell us what is Mallory-Weiss syndrome? Yes.
The tear of the esophageal mucosa.
Okay, good. So it's a longitudinal tear of your mucosa of your esophagus near the lower esophageal sphincter,
LES.
right?
Yeah, yeah.
Okay. Like for example, this is my esophagus, my stomach. So what happens here if we have a longitudinal tear to this mucosa layer, simply it's your Mallory-Weiss syndrome. So, what things can lead to this tear? It's simple. For example, if a person is forcefully, if a person is having GERD, that is gastroesophageal reflux, reflexing things back into mucosa. Okay, if a person is having severe vomiting, so with the pressure of that vomit, it can damage or it can injure this lower layer of your esophagus, right?
Mm-hmm.
Okay, so for example, if a person is alcoholic, alcoholic or bulimic, right? What happens in bulimia nerviosa? So they're just they just put them or their finger into their throat in order to vomit, right? Vomit out things. So this increased pressure of this vomit is going to damage your lower mucosa of your esophagus, and this longitudinal damage to your lower mucosa is your Mallory-Weiss syndrome. Is that right?
Mm-hmm.
Okay. So you can also have another condition which is known as Bohr-Haave syndrome. So what is Bohr-Haave syndrome? For example, if you have Mallory-Weiss syndrome and along with the mucosa rupture, for example, if you have rupture of all of these three layers and the food is just moving out, right? So it's Bohr-Haave syndrome. Simply you can think of you're boring or you're cutting all of the three parts of your esophagus. So it's your Bohr-Haave syndrome, right? Okay. Another thing which we are going to discuss is esophageal varices. So, guys, you know that, for example, if someone is having portal hypertension, like for example, this is his liver and this is his portal vein. If you are seeing portal hypertension, so we have certain areas inside the body, the junction where the portal system is in communication, or you have anastomosis with your systemic venous system, right? And then you have three parts in your body. Once in the lower esophagus, if a person is having portal hypertension, you are going to see dilatation of certain veins, and those dilatation basically show you the point where this portal or this uh, portal venous system is in, yes, in communication with your systemic circulation, right? And these are the anastomosis points, these 3 points. So one is your lower esophagus, right? So for example, if someone is having lower portal hypertension, so all of these three venous sides are going to be dilated. So you're going to see dilation of these veins at the lower esophagus, right? Giving you varices. That is esophageal varices. Okay, if you guys remember, for example, this is your umbilicus. So, um, uh, for example, if someone is having portal hypertension, so surrounding the umbilicus, you are going to see distension of the veins as well, giving you caput medusa. Remember?
Mm-hmm.
And what is caput medusa? Simply like snakes moving out of, you know, jar or a caput, right? So you're going to see the snakes like structure. And so this is your second part where anastomosis takes place, and your third part is in your rectum, right? Giving you internal hemorrhoids above the pectinate line, right? Above the pectinate line. So do you have anastomosis of your portal system with the venous system in 3 points, where you in your esophagus, around your umbilicus, and above your pectinate line. So if someone is having portal hypertension, you are going to see engorgement or dilatation of veins at these points, which is going to give you esophageal varices, rapid medusa, and thirdly, yes, your internal hemorrhoids. If they just dilate, it's going to give you like a dilated veins similar to hemorrhoids, right? So they are basically known as internal hemorrhoids above the pectinate line. So here now we are going to discuss esophageal varices, right? So what happens in esophageal varices? These are dilated submucosal veins in the lower esophagus, as we already discussed. Dilated veins in lower esophagus. Why? Due to portal hypertension. We already discussed why. Okay. Okay. So, for example, what's the common cause of death in those individuals who are having liver cirrhosis or portal hypertension? Yes, it's due to rupture of these esophageal varices. If they rupture, it can lead to hematemesis, blood, and your vomit. Simple. Okay. And if you are losing a lot of blood, it can lead to shock, and a person is going to die. So, it's the most common cause of death in cirrhosis. Yes, doctor. Can you just give us an overview of esophageal varices, along with that the association with portal hypertension and everything?
Okay, so when we have like portal hypertension, so it's like the three there are three locations which are like affected, in which we have the venous connection. So the first is around the lower esophageal sphincter. The veins are dilated, and it leads to a condition called esophageal varices. The
Okay.
second piece is around the umbilicus. So the dilatation of veins there will happen, and it's known as caput medusae. And
Okay.
the third location where it can happen is above the pectinate line or the dentate line, and that leads to internal hemorrhoids.
Yes.
Okay, so esophageal varices is happening at the lower esophageal sphincter. The veins are getting dilated, and it can rupture. I mean, like if the dilated veins are getting ruptured, so there will be like the blood in the vomitus, that is hematemesis, which further leads to shock and then leads to death. And this is like the most common cause of death in liver cirrhosis patients.
So it was all about today's session. Tomorrow we are planning to have a long session because we have a ton of pathology in this GIT. So tomorrow we'll be having a long session, and we'll be starting our class 1 hour ago. That is right from today's time. So we'll be having 2 hours of session, and we'll just try to finish off most of the pathology, right? So hope so you guys enjoyed today's session. So thank
Doctor, I
you.
have a question.
Yes.
When are you planning to complete 100 days marathon, like in December? What's
No,
your
this course is
schedule?
going to be finished off within like 7 to 8 days. The first pass.
Okay, in the next week, right?
Yes, like next week it would be finished off. Then we will be arranging the revision sessions, and
Okay,
we'll be taking NBMEs with that.
okay. And the whole marathon completes by, I mean, which date in
15
December?
December. 15 December.
Okay, okay, doctor,
Yes.
thank you.
Okay. So thank you. Thank you guys. Any questions? Okay. Thank you guys. Bye bye.
Thanks, Dr. Ahmed.
Thank you, doctor.
Bye.
Thank you.